All right. Well, thank you for the introduction. I'm Carlo Tornatore. I'm the chair of neurology here at Georgetown. And I'm going to talk to you today about this concept. There's been a lot of talk this morning about lifespan, but really nothing about brain span, which to my way of thinking, and I agree with Dr. Gladden, that the brain is probably the driver of who we are, obviously, but more importantly, who we're going to be from a quality of life standpoint, right? So here's the money slide, 35. That is your take-home message. That's your actionable item. That is the age when the brain starts to atrophy or degenerate. 35, okay? You can see this all over the place. We have a football player here from the Bears, wonderful. Not many players over the age of 35, right? You look at anything that requires significant cognitive ability, it starts to decline at age 35. If you look at anything that's major physical activity, 35. And why is that? Well, on the right, or on your left, is a picture of a neuron. It's one cell, but has multiple arborizations, right? It's unbelievable. And to your right is a group of them that are all scattered on top of one another, right? And they have thousands and thousands of connections. This is well known to all of you, this idea of, synaptic density. And so this is who we are. We have 10 billion neurons and we have trillions of connections where they talk to one another, okay? However, they start to decline at age 35, period. This has been well known for a long time, and this is based on MRI imaging as well as autopsy. And you can see there's really 4 phases to the nervous system. The first phase is when you're born, up till about age 13, the brain grows exponentially. It's a beautiful period of time. Excuse me. Then there's a plateau period from age 13 to 35. And there the brain there's remodeling that's happening. The number of neurons stays the same, but your connections are changing very dramatically. And that's when you have tremendous opportunity to learn, to train, to become physically more adept. Huge things go on. But then, starting at age 35, your brain starts to shrink, period. Okay, and it shrinks at about 0.2% per year, but it can be as much as 0.5. In my patients with multiple sclerosis, it's 1% per year. And that shows you that inflammation is a huge driver of brain atrophy. And then once you hit, unfortunately, 60, I'm there, then the rate of change exceeds even more, becomes 0.5%. Okay, so when we talk about, someone said this morning, hey, when should we be intervening? It's age 35. If you really are interested in brain span. And I heard I think it was Sarah, I think on the first panel, who said, oh, how are you going to convince young people that they need to start doing this? It's actually pretty easy. Why? When you're 35, think about that. There's 2 generations that are already behind you, and they are nipping at your heels, trying to take your job, for sure. Okay, and my son is 31, soon to be 32, and he already thinks that 18 and 19-year-olds, their way of thinking is so different. And so your message to a 35-year-old will resonate, for sure, because they are at their point where cognitively, they're still good, they can do everything, but they may start to realize, you know what, I am not as good as an 18-year-old or a 20-year-old or somebody who is AI native that's coming out of school and knows this, right? So I disagree. I think your message that I'm hearing this morning would resonate very much with people in their 30s and mid-30s, especially if they understand, hey, this is when your brain is starting to shrink. Excuse me. A normal aging of the brain is it's remodeling. It's not massive cell death. For the most part, the number of nerves you have are pretty constant after age 35. But what happens is it's the branching, the arborization that you lose over time. And this is the metaphor. On your left is the summer tree, young, healthy neuron, lots of branches, looks great. And then as you age, the tree is still there, but the arborization, the leaves, is less. And so it's not that you're starting to lose your neurons, but your ability to make those connections to one another is becoming less and less. And there's your opportunity, right? How do you keep that synaptic plasticity going? How do you keep those nerves that are there to continue to make new connections to one another? A lot of talk about putting stem cells in the brain. You don't need to do that, right? The cells are already there, and you risk causing malignant tumors in the brain for sure. For sure. We've run into this problem because I did the original stem cell work in the early 90s when I was at the NIH. I grafted stem cells into the brain of mice, and inevitably we saw tumors. Okay, so that's not where we need to be. What you want to do is promote synaptic plasticity and resilience in that way. And then if you look at, well, all right, what's normal aging, which is on the left, versus Alzheimer's, which is on the right, or other neurodegenerative disorders like Parkinson's or Lewy body dementia, or PSP. Normal aging, really, there's 4 pillars to it. And the idea is, how do we intervene in those 4 pillars as best we can? Number 1 is synaptic and dendritic pruning. How do we keep the pruning from happening? How do you keep those synapses so that they are continually there and they allow you to learn new things? All of us have synaptic plasticity. If you learn something new, your brain has made new connections, or those connections have become, have learned something, but have maintained that same pathway. And then there's the structural degeneration. And again, that's what I've been talking about, is just over normal time, brains, because of the energy required, where you have one neuron with all of these branches, the energy requirement is so huge that as you get older and as your mitochondria become less active, if you will, can't maintain that. And so you start to lose some of the arborization. And then number 3 is enormous vascular injury to the brain, right? This is an under-recognized, but an extremely important part of the reason that the brain ages, because as a vascular supply, as the blood vessels become atherosclerotic, which they do over time due to inflammatory process, the delivery of nutrients and oxygen to the brain changes, and that arborization, which requires enormous oxygen metabolism, is going to suffer for that. And so one of the greatest things we can do is to promote vascular health. And then the last thing are the cellular shifts. And these are, there's no question that as the brain ages, there is what we call the microglia, the resident inflammatory cells of the brain, if you will, change. And they become more active, if you will. There's the whole inflammasome process. And in fact, super interesting study where patients who are Alzheimer's were given a drug, it's a supplement called resveratrol. It's made from the skin of grapes, right? Very potent antioxidant. So they gave it to patients with Alzheimer's with the expectation that maybe it would attenuate the dementia. Well, after, when they look back at the MRI data, after a month, patients who went on resveratrol that had Alzheimer's, their brain shrank quickly. And people got scared. They're like, whoa, it's the opposite. This is causing the brain to shrink quicker. But in fact, when we looked at this data, those of us who are in the MS space said, your drug is working, because what happened is you have brought down the inflammation of the brain, and now the brain, it's called what we call pseudo-atrophy. And so it worked. But you just didn't follow those patients long enough to see the cognitive benefit of it. So atrophy and how we monitor atrophy is extremely important. And then on the far right is neurodegeneration, where you do lose the nerves. And this can be driven by deposition of amyloid, alpha-synuclein in people with Alzheimer's and Parkinson's, respectively. And so this is a totally different animal. And we have a panel coming up where several of my colleagues from Georgetown will be talking about what can we do with things on the far right? Are there interventions to prevent neuronal injury and the dropout that can lead to that really rapid change? So in normal aging, which is on the left, which I've just talked about, you can see these are the main mechanisms of action. Structural remodeling, which is great, synaptic impact, which we talked about. There are certain parts of the brain that atrophy a little bit quicker than others, which is interesting. So all parts of the brain don't equally shrink. And in fact, the very deep part of the brain, we call the basal ganglia, if we look at our patients with MS at the time of diagnosis, so people that are 29, 30, have already lost 30% of their deep gray matter neurons. That's astounding, absolutely astounding. If we look at Alzheimer's, it's a disaster. You have all this amyloid deposition, you have tau, the nerves are dying, there is incredible dysmorphia. The brain, as the amyloid moves from the entorhinal, the temporal area, moves to the back part of the brain, it becomes worse and worse. And this is just awesome. This is awful, just an awful, awful disease that has to be treated when people are pre-symptomatic in their 40s or even in their early 30s. And we can do that by checking blood levels of things called p-tau and amyloid. And we were talking about markers this morning. I heard some talk about, well, we could do PET scans and MRIs. Impractical. And I'm just being honest with you. I have no skin in the game here. Impractical. Because from if you're going to do this at a population-based level, scanning people and getting PET scans on them, forget it. Getting simple blood work that are the tip of the iceberg that may give us some insight into early inflammatory neurodegenerative process is going to be the way to go, 100%. And then I always find the super agers incredibly interesting. These are people who are older, and yet cognitively they are 100% intact. And you look at their MRI and they have almost no atrophy. How did that happen? Right? So it is not inevitable. There's something about these folks, these super agers, that are different than the rest of us. And what is that? Well, we think, we don't know the answer, but there's two things that we know are probably happening. And this is an important distinction. One is brain maintenance, and the second is cognitive reserve. By brain maintenance, this goes to a lot of the work that you all are doing, looking at different nutraceuticals, pharmaceuticals. How do we preserve physical tissue and minimize pathology? And then the second thing is cognitive reserve. All of us are going to lose some synaptic density and neurons, but how do we maintain cognition even in the presence of that? Yeah, got to hurry up here. So this is the reserve buffer concept. The idea is, as you can see along the top, there's that red line. We've been really good at lifespan. You can expand lifespan, but however, we've not been so good with brain scan. And so as we get older, the brain starts to decay, if you will. I hate that word. And there's a group of people that physically look not too bad, but cognitively are in bad shape. And so we need to look, I'll go through these real quick here, at how do we maintain cognitive reserve. And I think this is a hugely important part of what's happening. Educational attainment, staying cognitively active. There's no question that those who have early intervention, whether it's preschool, whether it is post-secondary education, much lower chance of having a dementing illness later in life. From an occupational standpoint, those jobs that are occupationally complex also are very much associated with the lower risk of dementia. And then, as was mentioned in the panel just before, social engagement. I think Jeff made the point that very important. You can't just have, the physical piece. You have to have the social engagement part of this to prevent breaking down, if you will. And for us in the neurosciences, we're going to talk about this tomorrow. We talk about the economic impact of neurodegenerative disorders. Conservatively, this is $8 trillion loss to the economy as we have people with dementing illnesses and the care that they require. And so what we want to do is increase this morbidity gap so that lifespan and brain span kind of parallel one another. And that what we want to do is work on those things that help cognitive reserve, the software of the brain, if you want to think of it that way. But then we also have to think about how is it that we can maintain the brain itself, the hardware? How do we keep it healthy? And then how do we promote that synaptic density from continuing on? I don't have the answers to it. And I think there are things that we can, and I'm going to stop. This is my last slide, I promise. But that the microbiology of brain atrophy, which is the whole point of my talk today, that we can lead to individual reserve, and that from a macroeconomic standpoint, as we improve brain atrophy, the end result is we'll have people who have less dementia and therefore less of a strain on the economy. And so I think these are just the ways to do trial innovations, which I talked about earlier this morning when I asked my question. I think there are biological targets, and there are also economic objectives that we have to say as a society that we agree that this is something we all have to do. My answer is pickleball. I see this as that I see older people getting engaged physically, it's socially, cognitively, it's all there. I would invest in pickleball equipment and all of that sort of stuff. It's the wave of the future. Anyway, I'm being a little facetious there, so I'll stop there.